Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform. Hi, welcome to Melanoma Matters. I'm James Larkin.
I'm Sapna Patel.
And this is going to be Clare Turnbull part 2. And the reason for that, as I think we said before, Clare Turnbull part 1 is we did an interview with Claire, which was a lot of fun. But there was just so much stuff that came out of it actually when you went back through it, which certainly to me at the time, it felt like we were just having a chat really with Claire, but it was so rich. You thought, and I agree with you obviously because I always agree with you, that we should actually split it in half and have part 1 and part 2.
Yeah, and it's not going to be even, I think, because the first half, there was just like a natural place to sort of cut it. The second half is more of a conversation about overdiagnosis. So what does that mean? That means screening tests before you have a history of cancer, screening tests when you have a diagnosis of cancer. So what is the value of, screening? For example, what's the value of screening every man on the planet for prostate cancer? Exactly. We don't have that direct conversation, but that's the equivalent. What do you get when you actually screen earlier and then increase lead time, but not survival time? What have we actually done, for a patient or for even the medical community? She talks about the Gilbert Welch paradigm. Does that ring a bell?
Yeah, vaguely.
Yeah.
Oh, farm animals. Yeah.
And
which one's your favourite? I can't remember. Rabbit, yeah?
Well, I mean, they're all kind of good. Snail, right? Bird. I don't know.
Yeah.
They're all
I think I quite like rabbit. Wasn't rabbit the one you need to look for, that need to be careful of?
The rabbit is the only one we can intervene on because the bird's already gone. The snail, the intervention's never going to matter.
Yeah. It all comes down to rabbits. But we knew that, didn't we?
I think. I mean, it's just a lovely analogy, though. It's an easy way to explain it to patients also about why you would or would not want to do screening for something. And then we talk about, she talks about some other things like predisposition syndromes and things like that. So episode 2 coming up.
Yeah. Enjoy.
So,
Fucked up.
Anyway, right, back to the script.
Rightio. So I'm going to pick up again about kind of rarer, lower risk variants, if that's all right, Claire. Maybe try and add a little bit. So, the broader question of these sort of lower risk variants, and I'm not just talking about in melanoma now, just thinking about other types of cancer, let's say, but I think it would apply to other diseases as well. Is it wrong for me to say, let's say, thinking about cancer, that a lot of the low-hanging fruit, if you like, BRCA and so on, has been well established, and then once we started getting into multiple variants which confer a slightly increased risk, my slightly nihilistic question would be, what do we do about managing that and counselling patients? Because increasingly people are having these tests done and wanting them done, and it just feels like it's really difficult to know what to say to patients.
Yeah, so you've got your high penetrance genes that came out of linkage studies, and by definition, they sort of are the most impactful ones insofar as we found them first because they have the highest risk. So BRCA1, 2, and in Lynch syndrome, MLH1, MSH2, and so forth. You then at the other end got these common SNPs, which came out sort of genetic epidemiologic studies, like massive case control studies, which individually only have an odds ratio of maybe 1.1, often much lower. You put them together to create a polygenic risk score with multiple variants. In between the two, there are sort of low intermediate penetrance rare variants, so genes like CHEK2, ATM, which we do test for in the clinic. In each of these categories, you need to be very clear that you have an accurate estimate of risk, whatever it is. That's not just on a gene level, but that you can be confident that the different individual rare variants in CHEK2 or whatever gene, that you can accurately estimate their risk, and that you have something impactful you can offer individuals at that level of risk for the respective cancer. And actually, that's often the bit where there are sort of geneticists who are very knowledgeable at the genes and the variants and how you add them all together. They're often quite separated from the people who understand about screening and intervention. And actually, I think there's a need for those communities to come much closer together, because certainly a lot of the screening recommendations we make when we identify someone with a genetic variant whom we've ascribed as being at elevated risk, we don't have any evidence that that package of screening that we're offering actually makes them live any longer, that it impacts on their mortality. We just think it's a good idea to do this test more often, whatever it is.
Yeah. Okay. That's very helpful. Sort of slightly confirm my prejudice, I suppose, if I'm completely honest. So then that sort of brings me on, I suppose, to some of the blood tests that are out there at the moment for early detection of cancers. And I know this is something that you have a view on and you've published on, but maybe just from the top, could you talk us through that a little bit? Because again, commercially, one feels like there's quite a lot of pressure to have these tests done.
I mean, so screening is just intuitively such an attractive concept, and it is that it just feels instinctively that if you do a test when someone presents with symptoms, and that's the test you use to diagnose the disease, maybe ovarian cancer is a good example, that if you present with symptoms that you'd have a pelvic ultrasound, a CA-125, that's how your ovarian cancer would be diagnosed. It seems absolutely intuitive that if you took those tests and went and did them to well people in the population, or in particular to people who you knew to be at elevated risk a priori, that would be a really good way by which you could pick up disease earlier and change outcome. But actually what you absolutely need, and it would be fantastic if and where it does, but you do need evidence. And ovarian cancer is a good example, that there were 3 very large trials, the PLCO in the States, UK Tox in the UK, and then UK Fox was high-risk individuals. So pelvic ultrasounds, 3 monthly CA-125s, that's pretty intensive. And they picked up cases early, that looks good. They actually, on initial data analysis, it looked like the stage of the at which the cases were ascertained was lower in those who were screened than the control group. They then followed them up, 0 impact on ovarian cancer specific mortality. And that actually gets to it's the Gilbert Welch paradigm of animals escaping from the farmyard. And you have the birds who are going to fly away, whatever. Even by the time you catch it on screening, that cancer has metastasized, so you're making no difference. You've got then the tortoises, which are trotting along pretty slowly. You're going to make no difference with screening, because actually you can catch them when they present symptomatically. They will be treated. So the screening only works on the rabbits, which are hopping towards the fence at a reasonable old pace. And that's when the delta of the time in catching them between screening and presenting symptomatically will make the difference in a proportion of cases between survival and death. And therefore it depends on the natural history of your cancer. And clearly ovarian cancer is a mixture of birds and tortoises, and there just aren't enough rabbits in there that your screening, or certainly with the modalities tested, was making enough of a difference. And to complete the analogy, the 4th type of animal is the snail, which is actually going so slowly towards the fence that it's only going to get there in about 200 years. It's essentially, these are cancers which are pretty much static and may even regress. But if you do a snapshot screen in a well person, you will find some of those cancers, and that they often are difficult to differentiate from the other type. And once you found it, you're then in a position, unless you can confidently write it off, which our markers are not good enough, you are then in a position where you either have to manage it or follow it up. So a classic example is prostate cancer, when there's a very, very high proportion of these indolent tumours will be detected, and our markers are just not quite good enough to dismiss them. So we follow them up. It's called a watch and wait prostate cancer. And the problem is we monitor them with scans and PSAs, which aren't great tests. And at some point, then the physician or the patient says, I've had enough, my PSA is up and down. I want the prostatectomy. So you end up with these snail lesions, the indolent ones, invariably with a sizable rate of overtreatment. The same is true to a lesser extent in terms of breast cancer screening, that the estimate is for every breast cancer picked up on screening where the intervention is mitigating an invasive progressive cancer, there are 2 that are overdiagnosed, overtreated, and would never have caused the woman, it would never have manifested symptomatically. And the overdiagnosis is a very problematic issue with screening, and that's a separate issue to that, whether you have enough rabbits, whether you can actually impact on the outcome. And it's a principle called lead time that, and this is why you absolutely need randomized studies, because it will always look like you've caught the cancer early. And if you have situation A with screening and situation B without it, so sort of counterfactual, and the patient were to die at the same point regardless, if you catch the cancer on screening, it looks like they've survived the cancer longer because you've given them an extra bit of time, which is the lead time. But actually they've died at the same point. All you've given them is a period of time in which they knew about the cancer. And it's both the lead time and the overdiagnosis are impossible to capture and quantify unless you do a randomized study and follow up the patients at least to evaluation of cancer-specific mortality. And I think that's what is really difficult, because screening seems so intuitively like it must work, and we all want it to work. And it would be fantastic if we could find more examples of impactful screening. But unless we do randomized studies following up to cancer-specific mortality, we will not be able to confidently quantify the degree of overdiagnosis or be clear that our screening is doing anything other than offering lead time.
I have a question about that, Claire. So when we introduce lead time with this screening protocol, is the erroneous conclusion then that whatever intervention you gave for ovarian cancer or prostate cancer, then improving that cancer-specific mortality, because it's from that time of earlier diagnosis to natural history of death from that disease? Or are those patients dying at the same interval or at the same actual spot in time, meaning that it does look like their cancer-specific mortality is impacted, and then teasing apart screening from therapy effect will be inherently impossible?
I mean, it's essentially, that's why you need a large randomized trial, so that you have a control group, and then you have to be able to, across the group, you either adjust for treatment differences, but essentially what you want is a sort of your comparator group to be managed identically to your intervention group, so that they are in all other regards the same. And then you have that comparison. But I mean, that's, as you say, there are a number of steps along the way, and that's why it's more accurate to talk about mortality. So you're comparing the mortality between the 2 groups, whereas survival is a sort of erroneous quantitation because it's from the point of diagnosis. But this gets back to your original question, James, which was around new screening tests. And again, if they are impactful and improve cancer-specific mortality, any of the multi-cancer early detection tests would be absolutely fantastic. And the technology is incredible. It is absolutely incredible that we can detect nanomolar levels of circulating tumor DNA, and we can use the methylation or other features to ascribe it to different cancers. I mean, it's absolutely fantastic technology, but we need to apply those same evaluations of having randomized trials sufficiently large and following them up to quantify cancer-specific mortality. And actually, in that regard, the bar's relatively favourable because you're grouping all cancers together. So actually, all cancers together is a relatively common outcome depending on the age group you study. So it does mean that sort of favours the trial design in terms of the length of follow-up required. there's then the issue of cancer-specific mortality versus all-cause mortality. So have you stopped them dying of bowel cancer, but switched them for, essentially they will die at the same time, but die of something else, or have you actually made them live longer? And that's the sort of debate, what standard a screening trial should be evaluated against. But you do need a lot more power, so you need a larger study and longer follow-up to evaluate all-cause mortality.
I mean, I just think that's such an important and powerful message, because it feels to me a lot like often amongst patients and sort of in general, there's incredible enthusiasm about new technology, which is justified. But, oh yeah, hey, let's get a test done. Actually, there's a load more to it than that, and it needs to actually be studied rigorously. Otherwise, for all the reasons that you've said already, and that the costs to patients and to society and resources from false positives, there's a whole load of other issues there.
Yeah, you're completely right. So the Pathfinder study was recently performed looking at the Gallery multi-cancer early detection test. And it recapitulated the early findings around the relatively low sensitivity for early stage disease that were reported in the original studies, which were done in symptomatic patients. So actually it was even lower in Pathfinder, which you'd anticipate in a screening population. But what was quite striking was it was around about 5 to 6 months required to give a final result to the patients who turned out to be ascribed as false positives. So that's a long time to spend having had a positive cancer screening test before it can be resolved. And I think that's the flip side. It's fantastic to have a test that can diagnose all different types of cancers, but to rule out them being present, so in the confirmatory test, can obviously take substantially longer than to do a confirmatory test of, from breast cancer screening or bowel cancer screening, where you're only asking a single question. So I think, as you say, that's the issue around false positives. And then there's also separate to that, and arguably probably less of an issue with the MSED, because I think it's probably not detecting indolent disease so much, but the issue of overdiagnosis is certainly a big issue. And there's a lot of interest in prostate cancer screening, and can MRI, mitigate some of the issues around PSA and so forth and so forth. But that overdiagnosis issue is a massive problem. And I think in terms of consultations, patients and patient advocacy groups and often clinicians sort of say, well, that doesn't matter as long as we catch the cases of cancer. But you do need to look at the ratios, because those will be 65, 70-year-old retirees who were happily about to go off and play golf and go on cruises, and you are going to make them into a cancer patient. And even if they're just followed up, that's still a substantial onus. But as I said, there's often over treatment initially, or during the duration of follow-up. So again, and those treatments may have consequences in terms of incontinence, impotence. There's all kinds of consequences which are very significant, and particularly if that volume of patients is substantial compared to the individuals in whom you've diagnosed a truly progressive cancer and intervene. And it all sounds like being the sort of bad news wicked stepmother, talking about the limitations and challenges of screening, but we do need to be more open and honest about this, because firstly we do harms. Secondly, there's opportunity costs, that if people are trotting along for their screening, they may be doing that at the expense of other types of preventative behaviour or engagement with healthcare. And then thirdly, in terms of our resource, that, is this money we could spend on getting better at rapid investigation and treatment of symptomatic patients who, by virtue of having developed new symptoms today that weren't there last month or the month before, are much more likely to have a progressive cancer, and therefore each week you can shave off and bring forward the time at which you operate or do their definitive treatment, sometimes radiotherapy, then there's good data showing each of those weeks is improving their likelihood of having a treatable, survivable cancer, rather than for many weeks left that increasing the likelihood of having developing metastatic disease.
May I just say something, James? Because she said so much there that I just am just in awe of. First of all, it's wonderful to have an ally on this. Be careful with our sort of screening and how we use it, because once you're in a medical oncologist's office, one of the things that happens in melanoma in particular is our recommendations for screening after a melanoma to pick up secondary melanoma metastases, et cetera, is varied. You know, for stage 2 to stage 4, the US guidelines say screen anywhere from 3 to 12 monthly. Well, that's quite broad. In melanoma of the eye, uveal melanoma, we have this massive debate. And respectfully, I go up against some very senior people in the US who insist that we must be screening these patients who are at risk of liver metastasis with an MRI of the liver. But we have yet to have any data that that screening tool does anything to improve survival. It introduces lead time bias. In fact, it's worse than that. It's everything you just said. By doing an MRI, if you really believe it's more sensitive, but that's due to, you know, skill of the radiologist reading it, the number that they see, et cetera. What you do is you pick up small abnormalities in the liver that are too small to do an intervention on. And like you said, then it can be months to resolve whether that's a false finding or a true finding, because now you need an interval for it to enlarge and do a biopsy, et cetera. That is often 3 or 6 months. And as I tell this, you know, well-seasoned group in the US, I say, all you've done to that patient now is given them anxiety that has impacted how they live their life for these next few months. Perhaps it's better to use the cursory CT scan that's cheaper, faster, less resource intensive. By the time it picks up something, it's ready to be biopsied potentially. Yeah. But we have this, you know, not only with the diagnosis of cancer and that, but we have it as we're following patients in their cancer journey. And I think we have to be mindful of all of these risks that can happen when we think, oh, liquid biopsy for everybody, you know, even though you might struggle to interpret it, or an MRI tool. MRI is not a screening tool, in my opinion.
I mean, I think you're completely right that, I mean, at least you are talking about the management of patients who walk through the front door with a problem.
Right.
And you are now engaged in how best to manage this problem. It's very difficult to randomize people to doing less, to doing the less sensitive test.
When they know.
So I think, exactly, I mean, I think that's a perennial issue. It's the same in the sort of radiotherapy de-escalation studies, that to try and engage funders, patients, doctors in studies of doing less is very difficult. But I think then, you know, so that is problematic. Trying, you know, applying this to the general population, the completely well population, is a massive problem. And actually, you make a point that's almost analogous. So I work in cancer genetics. We don't randomize. We can't randomize because these people are terrified. We've told them they've got a genetic variant that puts them at massively high risk of some types of cancer. And then we say, you know, how do you fancy being randomized to having something, you know, some kind of surveillance with X versus having nothing, so that we can see if X is effective? And because these will be tiny numbers of patients, you'd need an extraordinarily long follow-up, which is almost infeasible to deliver. So we have these intensive screening regimens that we offer to our patients with cancer susceptibility, for which we have no evidence for nearly all elements of them, whether they are actually improving their mortality. Pancreatic cancer screening is a classic example. And the NCCN have now recommended annual pancreatic screening for individuals who have genetic variants associated from age 50. And the pancreas has all manner of lesions. So you are just sort of, you know, starting a chain of events which will lead to biopsies, ERPCs, pancreatitis, you know, that there will be harms. But I know then I would be going for my pancreatic, I would be going for my CT MRI if it was me, because it just feels very intuitive that you want to do something. The other example is whole body MRI is very popular in a sort of imaging analogy to the MSED test. That, you know, why would you not want to look at the whole body, particularly if you have a pleomorphic cancer susceptibility syndrome like Li-Fraumeni, TP53, lots of cancers? Makes absolute sense. But we have absolutely no evidence that this is doing anything to detect cancers and make a difference. And it's quite plausible in Li-Fraumeni that they are either going to be birds or they're going to be tortoises and snails.
Yeah.
And you will also, just as I said, the snails, you will find a ton of incidental findings, which at best will involve lots of other follow-up scans and anxiety, but may actually involve overtreatment as well. And it's challenging to see how we're going to change this, because we're not going to be able to randomize. We're doing more genetic testing. We're putting more people in these buckets where we tell them that they're at high risk. As soon as you've told people they're at high or elevated risk or something, it follows that the reason you've done that test, if you've got something to offer them.
Yes.
But what we have to offer is actually not well evidenced.
So I've only got one more thing I want to say, I think, Sapna. So getting back to rabbits and snails and birds, I mean, I suppose maybe I'm naively optimistic about this, because I think the technology will improve. And so then if we had technology, for example, which early on could pick out in the disease the rabbits versus the snails versus the birds, obviously that would be great. And I think that will happen. I honestly, maybe it's naive. But I think your central point though, Claire, here is still the important one, that as and when we develop these technologies, they have to absolutely be rigorously tested before we start applying them widely to screening. And I think from the clinician's perspective, for patients in clinic, it's the easiest thing in the world to request a test. And, Sapna's mentioned already the ctDNA, NGS, all that sort of stuff. Oh, let's just do this test. It sounds sophisticated. It's impressive. Hang on a second. Why are we doing the test? And I just think that's a really basic part of what we do as doctors, at every level. Simple tests, complicated tests. How is this information going to help us? So, I don't know, Sapna, if you want to wrap up, but Claire, that really was a tour de force. We could have talked for ages. We didn't talk about cardiovascular disease or neurodegenerative diseases, and I know you're not necessarily an expert, but I think there's loads of fascinating questions in there as well. I don't know, maybe that'll be on for another time, but thank you.
Can I make one more point that you could then slice in?
You're the
boss. When I was talking, I think it's just a sort of gap. So I just sort of put in, you can. So, when we only had limited technology with genetics, it was slow and expensive, and we were much more selective about the patients we tested. So these were patients who had a young onset disease, strong family history, and also we only tested a very small number of genes because it was arduous and expensive. And actually, we only knew about those big hitter genes. If you fast forward now, the technology, well, it was the next generation sequencing was this sort of paradigm shift, making sequencing much cheaper and quicker. And what happened is we introduced it in the clinic only simultaneously to doing the large experiments, which allowed us to better understand the genes. But we're sort of building the aeroplane or flying the aeroplane while we're building it. And I think, as like with POT1, that as we've been able to do these much larger studies in the original write-up of POT1, because we only studied those multiple case families, we thought, oh, this is a very high penetrance gene. Then if we can do the very, very large studies, looking at unselected cases and controls, we can see these much more modest odds ratios. And the same is true across the board. And then there are these sort of very, very rare genes associated with syndromes where we've never really been able to get much of a handle on the effect size. But like POT1, they're going to be very small effects. But because we've expanded our clinical testing in parallel with doing the research studies, we're at a point where, particularly in the States, you guys like to test for 30, 40 or 50 cancer genes because it seems like a much better for value test.
Yes.
Why? And it is, in terms of the wet lab costs, it's near identical. So why would you test for, 3 or 5 genes tightly and well evidenced to be linked to that cancer type, even if we're not sure about the downstream management? Why would you stick to your testing of a handful of genes where for the same cost you can test 50? And I think we are a little bit of a point of we really need to regroup and reflect about this, because unlike in oncology, where you're managing one patient who you'll either ultimately cure or they'll die of the disease, when we find a pathogenic variant in the germline, we test the whole of the family. So you then have this cascading out in terms of, in space, and then the proband and all the family we do stuff to for decades. We will then do whatever our screening reactions to all these different findings, and if you're testing them for 50 genes largely unrelated to what they presented with, many of them associated with extremely obscure syndromes where we've got no idea about the risks. And then we have these sort of guidelines which says you need to screen 5 different organ systems for the next 2 decades. That is a very, very scaled up problem that we're just seeing the sort of tip of the iceberg of. But particularly as we put more and more focus and interest on early detection, and particularly then the part of that rhetoric is focusing on individuals at elevated risk, then this is just going to get bigger and bigger unless we're really sure about the risk and we're sure that our interventions are impacting on mortality. We are diverting a vast amount of resource and potentially creating a lot of harm without being sure we're doing any good.
Yeah, that you said so much there. Importantly, that is a very US phenomenon. Let's get more value for the same cost. But the danger, as I often tell patients, cancer patients who walk through the door, if we run this test that is going to test beyond the cancer that you have, I only know how to interpret the findings related to your cancer. So when the test comes up with a mutation for clonal hematopoiesis or a germline variant of unknown significance or a P53 mutation that might be contributory or might impart some future risk, I don't know what to do with that. And it used to be, and it's not so much anymore, that we were often told if you were going to order a complicated genetic test, you must have access to genetic counseling in order to help that patient and family understand. I think that's gone by the wayside as these tests have expanded in number. And perhaps what we really need is a real call to action to make sure that we're not, that we have the genetic counselors and that we're not overdoing it, like you say, causing this ripple effect for things that may never manifest, that may impact the proband for generations. This is a real problem. I think if we could take those panels and say, test, but just report the ones that are, hold the everything else for research, just report the ones that are relevant for this cancer, it might go a long ways. But, this is
doing. To my understanding, a big problem is that reimbursement is typically for one genetic test only, and the NCCN guidance is so complicated in terms of which genetic test you're eligible for based on various types of family history that, unsurprisingly, the logical consequence of that is to do an enormous test, and therefore you're covered and can't be sued without particular appreciation of the downstream sequelae, where essentially you essentially put a blue light on that patient's head and their family, that they're at elevated risk of cancer, but often we're not quite clear about the risks, and it will involve decades of intervention.
That's huge. Well, this was fascinating, not unexpected. Thank you so much for giving us your insight into what we're doing specifically in the cancer space. But it sounds like even just from a public health messaging, how we're setting policy regarding screening. So thank you, Claire, for joining us. This was such a joy to have you on.
Thank you very much, Sapna and James.
Hi, so welcome to the fact check for Clare Turnbull Part 2, which Sapna you're going to lead, and I'll, come in as and when.
Yeah.
You think? Well, I think that might be helpful, but probably not much. But go on.
So by now, people listen to the Gilbert Welch paradigm and probably picked their favorite farm animal in the analogy or in life in general. I think mine is the rabbit, now that you said it. She also talks about POT1 as a predisposition syndrome, as a tumor predisposition syndrome, and how I think you were asking her, it's a melanoma podcast. People would be interested in melanoma. And she says, yeah, look, there's a tumor predisposition syndrome, pot1, that can be associated with melanoma, but it would not be worth it to screen for it, because actually in series, you're only picking up kind of like 0.5%. So I think I sent you an article on that gene. I don't know if there's anything there that you think is worth mentioning.
No. Pancreas cancer gene testing. No, to be honest, I suppose in our melanoma clinic, we would always ask about family history of other cancers as well, I suppose, just as a routine thing. And then anyone actually with any sort of what we would regard as a fairly significant family history, we would probably ask the geneticists in that situation whether it was worthwhile referring them. And I would just make the point, I may have said this before, that these things change quite quickly. So I think adrenocortical cancer was the example I used before. I mean, I've been looking after adrenocortical cancer a long time now, kind of 20 years. And it came to light in the last 12 months, I think, that actually it's worthwhile doing genetic counselling people who've got adrenocortical cancer, because according to, if you like, the updated guidelines, there'll be a small proportion of those people who've got a potential family history. So, I mean, these things are moving fairly quickly. So I suppose the take home there might be that if you're lucky enough to have access to geneticists, which we do, it's usually quite easy just to send them a message or something, or ask them, is this someone where they might benefit from coming to clinic and having a discussion about genetic testing? So I slightly fudged that answer, but it's true.
Well, I actually would caveat that answer. A lot of clinical genetics clinics are not run by people like Claire, thoughtful, careful. They're run by almost practitioners. I mean, I don't even know how many are fully run by MDs, but they're run by people who are just reading guidelines. So it's a little bit like a travel clinic, right? They'll just open up what country are you traveling to? What vaccines do you need? So sometimes I feel like clinical genetics clinics are a bit like that. They're just going to say, what cancer do you have in your family? Okay, based on that, here's the testing you need, without really giving thought of is the testing of value? Is it really adding to lifespan if we pick up something, or are we just adding to anxiety? What about false negatives, false positives? And I think Claire is the one who's very careful about that, because I think she would potentially see people like this thing you just mentioned about adrenocortical, right? A perfect example. For all these years, there was never some suspicion that it was familial. It to be a rare cancer. You didn't necessarily think when you diagnosed one, you diagnosed a proband for a family. Yet now there's some guidelines saying, hey, maybe test beyond. And that's kind of interesting, because how valuable is that testing, the cost of that testing for what you might pick up at some small number. But I think that's the stuff that Claire did that I found really fascinating. She's not just one to say, here's a screening test, or here's a test, use it. She was really careful about what is the ad that you get when you do that screening test.
Yeah. Listen, I think that's just such a brilliant point, and I'm not just saying that, but I think it's a really great point. And I was going to say two things actually about that. First, I think we're very fortunate to work with people like Claire. The other main geneticists we work with are actually oncologists as well. Mm-hmm. So Ros Eels, for example, is very well-known prostate cancer oncologist, radiation oncologist by background, and geneticist. And then Angela George is another colleague who's dual qualified actually in genetics and in medical oncology, and she treats gynae cancers as well. So I guess we're very, very fortunate here to have people where we can actually have a discussion about the pros and cons, which is great. And it's a massive issue for patients having genetic testing. And quite often, I mean, this happened to me last week. I was talking about the possibility of genetic testing with a patient, and then, of course, they start naturally asking all these questions, and I will say, well, look, this is a complicated situation. I can't really answer these questions. The first step would be you going and talking to a geneticist, understanding the benefits, the risks, the consequences of the test for you, and sometimes there might be insurance and all sorts of other implications, as well as the potential consequences of that information for your family. And you can't really do justice to that without someone who really understands, without meeting someone who understands the kind of the characteristics of the tests and the potential consequences of the information. And again, this stuff can move quite fast. And then my other soapbox point, which I probably made before leading on from that, is a lot of this stuff gets back to what do we hope to get when we do a test, which sounds simple, but it isn't. And I remember at medical school, I must have said this to you before, this was in Oxford when I was doing clinical, we had this whole session with this guy called David Sackett, who was Canadian originally. Then he went to Oxford and he wrote this book, Evidence-Based Medicine. And he was very much into this whole question of what do tests do? What information are you hoping to get from that test? What are the characteristics of the test? And then if you do get the information, how do you interpret it?
What are you going to do?
And there's obviously a whole big theory whole big theory behind this. And it's just the easiest thing in the world for all of us as physicians, I think, to say, oh, let's just do a test, right? Let's do a test. Let's do NGS. Let's do this. Let's do that. And it opens up such enormous questions. And I'm really strict when I'm talking to fellows and trainees, and they're sick of hearing me say, any test. Is it a full blood count? Is it PSA? Is it cholesterol? Is it an MRI scan of the spine? Okay, yeah, we can do the test. But before we request or order the test, let's just think about the information that we might get from the test and if it is going to help us, or more importantly, help this patient in front of us. Because do you know what? You can order a test. That's easy. Actually talking with the patient about the value of the test and the yield of the test takes a lot longer than ordering the test.
That's a great tip. I might steal that from you if that's okay. Teaching by Larkin across the pond. Why are we ordering the test, and what are the potential results you can get? And then how will you explain that when that MRI of the spine that was meant to look for cancer comes up with degenerative disease and now disc disease or a bulging disc or this and that, and now they want you to address that, or it comes with a bone island, or so the one that came up in the episode is, without naming sort of brand names, here in this country, there's tons of these concierge type of blood tests that are being sold and marketed to kind of people in primary care and wealthy individuals to order just a panel of ctDNA on the blood before you even have a cancer diagnosis, right? And you and I know how troubling that can be. So not a cancer predisposition test, but just like sort of a shotgun panel. And Claire mentions, in the US, obviously they like to do this kind of stuff because where you might sequence for one gene, you could sequence for a whole panel for the same price. So just get more value. So we're so value focused here that we forget, what are we doing with these results? So now you have a test that comes back with a P53 mutation. So what? What does that mean in the absence of actual, visible tumor or a second hit? So this is challenging. Why are we ordering that ctDNA test in primary care? And what are you going to do when you get this complicated report that really is just telling you about clonal hematopoiesis or a variant of unknown significance, or worse, a pathogenic variant for which you're not even familiar, you don't even know what to do, you don't have clinical genetics to send them to, you've ordered a test that basically puts you over your skis now, and you don't know what to do with that patient. So anyway, this is...
No, I've even got I've got two more things to say, which you just sort of triggered in me, which is that I would even go back even more fundamentally than that. Certainly as doctors, as physicians, when we see a patient, what do? We'll take a history and we'll examine them. We might not always examine them. And then we'll think about what investigations are likely to be helpful in that situation. And that's how I see this. Sometimes investigations are helpful, tests. Sometimes they're not. Different tests have different characteristics in different situations, sensitivity, specificity, predictability, so on and so forth. One important point about how to think about tests. And then the other important point, and I'm strict about this, is that if you request a test in consultation with a patient, you have requested that test, and it is your responsibility to talk to the patient about the information and to interpret it. And if someone else has requested a test and they come to me, I will say, I'm really sorry. Actually, the person to interpret that information is the person that requested the test. I cannot interpret that information because I did not request that test. And maybe that doesn't fly in all clinical scenarios, but I'm fairly strict about it. Even when it comes down to things like doing PSAs and cholesterols and all these other kinds of things that people will ask for, I say, yeah, okay, but who's going to interpret the information, and so on and so forth. So I think a bit of thought. I think a lot of thought, in fact, is required when we're deciding what investigations to do for all these types of reasons. And I think it's just so easy to uncritically request a test without thinking about if that information is going to be helpful or not. So that's it. I finished my soapbox now.
You said two things, though. I triggered two things in you.
Yeah, the first one was about investigations being part of the kind of broader assessment of the patient.
Oh.
And the second one was about if you request the test, then you are responsible for the results and interpreting them. Those are the two things.
Fair. I like that a lot. Well, I mean, massive kudos and thank you to Claire for coming on this program. You've obviously known her for such a long time and knew she would shine like a diamond like she did. It was so cool to just sit back and listen to her go, because she clearly has so much to say. We didn't even get into probably scratching the surface on topics. So anyway, fantastic. Maybe I should bring her over for a SWOG meeting, because she would just crush it, I think, when it comes to what we do in some of our interventional stuff.
Let's hope she features prominently at upcoming meetings with a big audience, shall we say. Leave it there.
Okay. All right. Thanks for this. Thanks, despite all the technical difficulties.
Thank you.
Multiple volumes that will probably be on this. Okay. Yeah.